make anybody's move. It's really funny. Once you set up in your first year, you stay in that seat for like 4 years. And then you got to just rotate around the room from first to fourth. So for 10 minutes, my goal is to really just give some take-home points of kind of what I do, maybe based on a little research, maybe not. And we'll get going. So I started kind of on the continuum because while GI bleeds are a little sexier, it's very rare that you get a really, really bad GI bleed. And then as all the evidence that Don just said, you're just kind of praying. You're calling GI, hoping they live, hoping you don't put it in that Blake more. And it's kind of up to the patient, maybe more than it is to you, but we throw the kitchen sink at them. I'll get to that point at the end, but common things that happen we see every day. So I kind of started with GERD, and how do we diagnose GERD? Or how do I diagnose GERD? It's mainly by ruling out chest pain, right? So, because I'm like, does this 55-year-old have chest pain? I'm like, no, okay, you've got GERD. Have a PPI or H2 and go home. Or the resident comes up and says, I've got a 52-year-old with chest pain. It's burning in the epigastric region. And I'm like, I know what you're selling. You know, you're selling me GERD here. You want to send this patient home? Okay, so that's kind of how we do it. And then what do we do when we ruled out the chest pain and say they have GERD? Don't forget lifestyle modification on these people. It seems that we often overlook it. You know, we talk about tobacco cessation in the ED and other lifestyle modifications. They do work every so often. This is a teaching point when this person actually came to the ED with their chest pain because they were afraid they were going to die. You can say, you know, if you BMI greater than 25, they've got more to lose and they've got more to gain from decreasing their GERD. If they've increased weight recently, that'll also do it. So it's a good opportunity for you. I don't say use it and just or forget about it and give a H2 blocker or PPI. Head of bed elevated at night also helps. I kind of look because you know I'm into these myths and the perpetuations of what everybody tells patients on tobacco, caffeine, and alcohol. I kind of believe it's true, but I can't really find any evidence on it. And you would think it would be out there because the amount of people that have GERD in this country, it's an easy thing to research. But there's nothing that I can find, and when I look for it, they say there's nothing you can find. So H2 versus a PPI, I don't know, whose preference? Show of hands, who gives an H2? Who gives a PPI? Is it because of what you have available? Or just what you memorized? Any other reasons?
PPI is time to effect.
Like the H2 blocker?
So PPI has that like rebound effect, and we stopped it, so I tend to use the H2 first.
PPI is rebound, Tums is rebound. So when we look at end outcomes, this is a study that doesn't really show the end outcome of the patient, whether GERD got better, but just shows acidity in the stomach. And the PPI works a little bit better, it decreases the acid more. Do I care about that alternative outcome? I don't know, not really. I think they're probably both pretty okay. The GI specialists, for some reason, want first line to be H2 blockers and then switch to PPIs. But everybody has their different preference, and there's not that much of a difference where I would stick my foot down and be like, okay. This maybe is a little teaser for the end if we get to it. If I finish in 9 minutes and 30 seconds, then we'll get to this. I have this thing about every nurse and telling patients to take their Motrin after meals. I really want to see the evidence on that. I've been studying it for about 10 to 12 years now to find any evidence and asked every GI specialist I know. I think I have the answer. Peptic ulcer disease. So if they do have GERD and you send them home and they come back in a year or two, maybe they develop an ulcer from all this acid in their stomach. How do you treat these people? Now, the guidelines are you've got to diagnose it first, which is kind of a problem for us because we're not going to get a scope in the ED to diagnose an ulcer and do a urease test and then say you've got H. pylori, you've got an ulcer, this is how I'm going to treat you. So nicely, the GI specialist said that we can treat without a scope, which makes a lot of sense for our patient population that we see. We're just not going to get that all the time. So why are we going to, and how fast are they going to get follow-up at GI? Probably not that fast. It'd be nice to help them in the meantime. So I just kind of recommend to look it up every time. It's going to be the triple or the quadruple therapy, and you can look up which ones it has. The key point in this is you're going to have people that come in with ulcers that have been treated before. Ask them if they've been treated before, because it kind of changes your treatment. If they've been exposed to the macrolides before, you're going to do a different triple therapy. So if you memorize just one, not all patients are the same, of course, and you're going to change that regimen. And penicillin allergies also. So now the person gets to the GI. So they have an ulcer, ulcers are kind of the same thing too. Is this chest pain? No, this isn't chest pain. You have GERD? No, it sounds more like an ulcer by history. We're going to treat you with triple therapy because we can't scope you. And then they start bleeding. So the ulcers start to bleed. And what do we do for those patients when it gets to it? And Don kind of went over it. And I kind of really enjoyed how the studies kind of show no benefit to one thing or the other. And I always start thinking, if there's no benefit, do they work at all? Like, if we're comparing two things that don't work, then there's not going to be any superiority. So how do you diagnose it? I like this study because I like likelihood ratios, and it can really show you what on the history is going to lead you to a GI bleed, because you have a continuum of the person spitting up blood in front of you to the person that said, I vomited and there's a little bit of blood in my vomit. And what do you do for that person? Are you going to do a rectal on every one of those patients? Now, I've worked with a lot of you, and I don't find a whole lot of value in it. If they told me they were bleeding, I don't call them a liar. I kind of work it up as they had some blood somewhere. And so if I do a rectal to look for their guaiac and it's negative, do I say, no, you weren't bleeding because your guaiac's negative? No. I'm still going to treat them the same way. If it's positive, well, they just told me they were bleeding. So, it kind of, if I've got a drop in H&H and I don't know why, and I'm searching, then maybe a guaiac helps me. But otherwise, I'm looking at other things. For the minimal cases where they just had a little spit up, which patient is safe to send home? And that's kind of where I go to this. A drop in H&H that's significant enough, I'm like, whoa, maybe we should get them scoped today. If this person's vitals are fine, their H&H is fine, all the other diagnostics that I'm going to run, the BUN creatinine, you can see the different likelihood ratios. But it really depends on my pretest probability, right? So these likelihood ratios are only good of my pretest. If this person's spitting up blood in front of me, I don't really care about these likelihood ratios. They've got an upper GI bleed. I see it, But if they don't have anything, then I kind of utilize this to see which are the safe patients to send home and which ones aren't. So again, nothing you have to memorize, but know that it's out there, and you'll see it. This is a fun thing that happened in the last 10 to 15 years, and I don't even know if it's a controversy anymore. Are we dropping NG tubes for all your GI bleeds? We're really fighting it. About 10 years ago, we seemed to be dropping NG tubes for every patient. I like this one because the end outcome was, if you drop an NG tube, they're going to get a scope faster. So, that's great. Let's torture the patient so GI will come in and scope the person. Probably not the reason why we want to drop a GI tube, but we have in the past. I might have in the past. This one is, what are the true end outcomes for nasogastric lavage? I'm not really buying it. So this they compared erythromycin to NG tube placement for upper GI bleeds, and they compared their outcomes, and there wasn't any difference. This kind of goes back to my thought, if there's no difference in things that I don't think work, maybe both of them don't really do anything. So again, probably another reason why we don't do NG tubes. This one is our guy. So this is one of the definitive ones, I think, that kind of settled it, at least in this department in 2010. Paula Medesi, along with our research division, did their study and says, it really doesn't have any value whatsoever. Don't do it. And I think when Nick presented this in conference, it was like, don't do it unless you really just want GI to come in really fast and you can torture the patient. So the PPIs, like this is another thing. Like every time I have a GI bleed and I call GI, they said, how much of a PPI did you give? Did you give 80? Did you give a high dose? Are they on a drip? And I'm like, does it really help that much? Am I going to decrease this acid in this bleeder and they're going to stop bleeding all of a sudden? It supposedly has some benefit, very mild, if that. You're going to see, every study is different. You're going to see some that have no benefit. I don't see a huge downside to do it. Plus, I don't have GI yelling at the other end saying, oh my gosh, I can't believe they didn't give 80 of Prilosec or whatever they want, Pepsid. But I think there's also some indication creep on it. So now we're not only giving like PPIs, we're putting them on a drip, right? Like that's a common thing. Are they on a drip? There's no evidence that a drip works, none that I can find. So I'm kind of a steward of our nurses' time. To hang a drip and to monitor that drip is kind of a lot of work. You may want them to do something else for your patient, or if that person opens up and starts bleeding, we've got a whole other set of problems happening. So it's easier maybe for me to talk to the GI consultant and say, no, I didn't put on a drip, but I gave them 80, and if you want to put them on a drip, go ahead. But do it when they're out of the ED, because I don't want it to take the time of our nurses. We discussed the somatostatin and the octreotide. Again, I think the reason why there wasn't any benefit in these pressors to somatostatin and octreotide is not all patients are the same. Not all the patients are the same in each study, and there's a huge amount of heterogeneity in all these studies when you combine them. So then you get kind of no benefit. In theory, it makes sense. Somatostatin is going to decrease that splanchnic circulation, and if they're bleeding from that area and you decrease the circulation to that area, all right, I buy it. Is there a big downside to it? I haven't seen it yet. We don't have it in a lot of places. Octreotide, they're saying, works similarly, but the theory probably isn't the same. It's more of a secretions than decreasing the secretions from the pancreas rather than decreasing the splanchnic circulation. So maybe a little bit different. The one dose that are studies seems to be okay.